why, but that's why what I prefer. So if you have to know what is an artifact, then it can be, if you see the definition on Google, it says that it is an object shaped by human workmanship, which has got a special interest. It is because of it has got some historical or archaeological interest. If you see in Latin, the ars means art or skill, and factum means made. So anything which is made by human, or any artificial product which is made by human, which is of historical or archaeological interest, we call it an artifact. Now, this is pertaining to history or archaeology. But what about science? If in science, something which is observed in a scientific investigation or experiment that is not naturally present but occurs as a result of the preparatory or investigative procedure. And medicine being a science, we have to take this definition seriously here. Now, these are some artifacts which are there, which we see in archaeology, which is like this. These are some Harappan seals, which you can see. There are these instruments which are of from the stone which are made. So, what is an artifact in terms of histopathology? If you have to define for histopathology what is an artifact, then you can define it as a defect or distortion that occurs as a result of the way the tissue was handled, right from its collection. That means when we are collecting the specimen, through its transportation to the lab, and also during the histotechnical process which goes on, like processing, embedding, and staining processes. So again, in other words, artifacts can also broadly defined as any changes in tissue between removal at surgery and microscopic examination that are caused by the process rather than reflecting pathology. That means the artifacts are not a pathological findings. These are usually due to mechanical or physiological factors. So why should we know about the artifacts? What is the relevance? What is the relevance in histopathology? So artifacts can be confused with normal structure or pathological chains. That's why it can compromise in coming at the correct diagnosis. It can hamper the accurate diagnosis. It can cause alteration in normal histological and cytological features, and that's why again it will affect in making the good opinion or accurate diagnosis. And sometimes artifacts can be so severe that it makes tissue so completely useless that you cannot make anything out of it. So that's why one should know about the artifacts in histopathology. Now, artifacts can be categorized as two, like minor artifacts and major or very excessive artifacts. In minor artifacts, the artifact usually involves only a small portion of the specimen, and it usually do not interfere with the process of arriving at a diagnosis or opinion. So although it is these are the artifacts, but you can be able to arrive at a diagnosis reasonably. But in when the artifacts are major or excessive, it involves the entire specimen, and the specimen is rendered useless for making a diagnosis, and this is really serious thing. Because histopathology, when we obtain a specimen, it is not something which are like in hematology or even in clinical path wherein you can ask for sample again. In histopathology, sample is removed. That is a very precious sample. So you do not want these major artifacts to come into the specimen. Now, artifacts can be introduced in the tissue during any of the following stages. It's right from when it is a surgical procedure, or be it a radiological procedure where you are removing a small biopsy or taking the entire tissue out. It can be during fixation process. It can be during tissue processing, embedding, microtomy, mounting, staining, cover slipping, and even during the storage, you can get some artifacts within the tissue. Now, what are the pre-fixation artifacts? That means these are the artifacts which occur in tissue, or these are the distortion or defect which come into the tissue while we are procuring the specimens. So these are produced prior to or during the collection of specimens. These are usually related to surgical procedure, or it can be related to the radiology procedure where they are obtaining the tissue. And these are because of the handling of the tissue during the dissection. Now, these can be physical or chemical artifacts. Now, let us look at this physical artifact. Here is a true cut biopsy from a lymph node, and you can make out that this is the core of a tissue of the lymph node, and you cannot make out anything even on the high power. That's the cells are completely crushed, and the nuclei look like they are completely elongated. So what is it called? It is a crush artifact. This has been produced because of the needle which they might have used, which must have been old needle, or they have reused the needle, or tissue could be so hard, like in sometimes in a mediastinum biopsy, or there is a mass in the mediastinum, it can be so hard that the while taking the tissue, the tissue gets compressed, and so that you produce an artifact which is called crush artifact, and you cannot make out anything about the cellular details. In luckily in this case, I was able to do CD20, and CD20 gave me result, and I was able to tell them that at least this is a B cell lymphoproliferative process, or B cell non-Hodgkin's lymphoma. But sometimes, because of this severe crushing artifact, you may not be able to give any diagnosis, and you will have to ask them for a repeat biopsy. So crush or compression artifact are usually they cause artificial elongation or distortion of cells or tissue. These usually occur in a tissue which lack or have minimal supporting stroma. For example, it usually you see it in small cell carcinomas or lymphomas or high-grade hematolymphoid malignancies, or even in small round cell tumors. These are usually seen in the tissue cells which have got high NC ratio, and so that you can see that the nuclei get elongated, they get pushed to each other. What we call as a nuclear molding can be seen because of that also. And because of that, there is a spillage of cellular contents in the stroma, so that the tissue looks quite blue, but cellular details are not well seen. Now, similar to this, there is something called as Azzopardi phenomenon. It was first described by pathologist Professor John G. Azzopardi. And what you can see here, that this is a tumor which is a highly apoptotic tumor. There is a necrosis also, and there is something which is deposited around these small vessels like capillaries or venules. You give the deposition of this very blue material, and this blue material is nothing but it is a DNA material which has been released from the nuclei of this very high grade malignant tumor, and those gets deposit around the vessels. And this is what Dr. Professor Azzopardi said, that this is DNA material, and this can be actually used to make a diagnosis. I mean, this usually you see again like a crush artifact. This artifact usually seen in tumors which are very high grade, like small cell carcinomas, like lymphomas, or sometimes even a small round cell tumor. So it actually helps in making a diagnosis. If you see this kind of phenomenon, you know that this is a high grade tumor, and you may be dealing with one of these differentials. Now, this prefixation artifact can be seen in bone marrow trephine biopsy like this. You see this bone marrow trephine biopsy wherein most of this in intratrabecular spaces look empty. These are actually artifactually empty spaces wherein the marrow elements have fallen out, because what happens that if they use a reused needle when they are going through the bone, and they are trying to aspirate from the same side, the artifactually the bone marrow elements fall out, and you feel like these are the empty spaces, and it can actually make it completely inadequate for any opinion. So you have to tell them that if it happens again and again, you have to go back and tell your clinical colleagues that this is what is happening. You may have to use good needles, and also stop aspirating from the same side. When they are aspirating from the same side, this kind of artifacts are produced. They have to change the direction of needle when they are actually taking the biopsy after the aspiration. Now this is a whole mount, or this is a section of ectocervix, you can see, and you can see that there is hardly any ectocervical epithelium is seen. There is actually, it looks like there is no ectocervical epithelium, that there is an artificial loss of ectocervical epithelium. In high power also you can make out that there are hardly few basal cells can be seen, but there is no superficial layers of the ectocervix, or the surface epithelium is hardly seen. It looks like it is denuded. But this is an artifact which is usually produced by, during the laparoscopy, they use something which is called as manipulator or uterine manipulator to steady the uterus for laparoscopic excision or removal. and that's why, because of this friction, the superficial epithelium of the ectocervix gets denuded, and that's why it seems like there is artificial loss of ectocervical epithelium. This is another prefixation artifacts wherein you can see that on the left hand side image, this is again a cervix, wherein on the very extreme left of the image, you can see there is a lot of very dark staining. This is what it is. It is a thermal artifact. On the right side, there is a tissue which has completely got a complete thermal artifact. In fact, you cannot make out which tissue it could be, and this is what is called as a thermal artifact. Thermal artifacts are usually called because during the removal of the tissues, they use electrocautery or they use a laser, and because there is too much of heat, there is a denaturation of the proteins in the cells, and because there is a lot of dehydration of cell, there is a new denaturation of proteins, and this causes acidophilia in the tissue, and that's why you get such a dark staining. And if it is so severe, sometimes in the biopsies you may not be able to make out any cellular details. Thermal artifacts are not only caused during the collection of the specimen, but they can be caused during the processing also. If there is the wax penetration or paraffin penetration which happens during the processing, if the temperature of the paraffin is too much, then also small biopsies can get the thermal artifacts. Again, while you are embedding it, if your forceps which you are embedding with which is very hot, then the small biopsies can get thermal artifacts. Also during the cutting of the section, if you're taken a section on the slide, and now you put it on a hot plate, and the temperature of hot plate is too much, or you even in an incubator you are going to try this slides, there is a temperature is too high, the small biopsies can get these thermal artifacts, rendering tissue inadequate for opinion. So this should be avoided in all stages. You have to find out where these are happening. If there are too much of thermal artifacts happening while taking out the tissues, like let's say they are doing a laser excision in a vocal cord where a small tumor is there, and there is too much of charring of the tissue, then you have to tell your clinical colleagues that see, this is what is happening. So they might have to lower their milliamperage of the Holt, and that might give less thermal artifacts. So even prefixation artifact can be foreign material artifacts. These are usually can be gel foam or gel film. The tattoo which now the people do for cosmetic reasons, that can also give a foreign material like artifact. Local anesthetic agents, when they are injected around the or within the lesion, can also produce artifact. Suture material, must have seen suture material artifact. Glove powder, when you use a glove, the gloves which have got a powder, that can also give an artifact. And cellulose material or vegetable material within the tissue can also produce an artifact. Now look at these two images. In the both images, you can see that there are this very filmy looking basophilic material of variant sizes or films. This is nothing but it is a gel film or a gel foam. This is an absorbable gelatin which is used in tissues where they are expecting, surgeons usually use this. When they are expecting that there's going to be a lot of hemorrhage or bleeding into the tissues where the tissues are quite hemorrhagic, like let's say during the liver resections or the splenic resection, or even during some spinal resections, they use this material so that they can prevent the excessive bleeding. And this gelatin in the after the processing and the staining looks like this. These are different size films are there, blue films, and you can see that there is some blood in between, and this is how you identify the gel foam. Now in this image on the left side, you can see something which is looks like quite refractile even in H&E and producing a foreign body type giant cell reaction. This is nothing but a suture granuloma in a tissue. Now, when you see the suture granuloma, it is on the left side, it is under the usual microscope or wide field, you look like this. But if you polarize it, it gives a nice birefringence, and that's how you identify that this is a suture material. Now, suture material can come of because of many things, like the patient has already operated before, and that's how you know that something has been done to the patient, and that's why suture materials are there. The reason we should able to identify suture material, that if you identify them gross, you should try to remove them, because if they are in a sections, that can cause serrations or the problems in the knife, and can produce the knife chatters or knife scores in that. So you should be able to recognize the suture material during the grossing or processing, and you should remove them. Otherwise, it's you just have to in section, if you see it, that means that something was done to this patient prior, or there is some surgical intervention done in this patient. Now these are three images. You can see that the top two images, you can see some material which is there within this very granular material which is seen. This is actually content of appendix, in which you can see what is called as a cellulose material or a plant material or a vegetable material, which comes from what we eat. And if you put them under the polarized light, you can make out the nice plant cells, which are square or rectangular cells, and that's how you recognize that this is a cellulose material or vegetable material. um, these are usually seen within the contents of the intestine. So if you do not wash it properly during the grossing, you'll be able to this material. Many times in appendix lumen, you must have seen this. Now, the other important thing you have to remember, that sometimes it can be very helpful clue. Like if there is a intestinal perforation, and you are seeing a specimen of the intestine, you on gross you may not be able to see a proper perforation, but on the serosa there is an exudate. Within an exudate, if you see a vegetable matter like this, that means it has definitely come from the lumen, and it has perforated, and come to the serosa. So that's why you are seeing this material there, along with obviously inflammatory infiltrate and exudate. So that is also a clue that this is actually a case of perforation, but perforation may have sealed off during the course of the disease. Incidentally, in this same appendix, in the lumen, we also saw a parasite of E. vermicularis, which is a common finding. Sometimes you see them. This is a pap smear or a cervical vaginal cytology smear, wherein you can see that on the left and upper corner image that there are squamous cells of superficial type or some intermediate type with the inflammatory cells. But on high power, one start to see there are some these very round or oval or whatever polygonal like structures are there with some very irregular pycnotic like material inside, which looks like it could be a cell, but it doesn't look like anything like a basal cell or parabasal cell of the cervical epithelium. And even on the higher power, again you start to see they look little reflectile, and there is very irregular something which is more darkly stained area within the center. And if you put them under the polarized light, you start to see that these are actually something which are like a cross like thing. You can see these are nothing but these are like this is called as a starch or a glow powder artifact. The glow powder crystals, they polarize like this, which is something which is called as a Maltese cross like polarization. And this is how you identify. This is usually seen when even when somebody who has removed or taken the pap smears has used the glowed the powdered glows, or sometimes rarely you can even see in tissue as a granuloma or like a starch granuloma you can see sometimes. So let us take a poll question. Which of the following is not a prefixation artifact? First answer is crush artifact, second is thermal artifact, third is a gel foam artifact, and fourth is autolysis artifact. I think we should give our attendees a few seconds to answer this question. So as I can see from that, most of them are opting for autolysis artifact, which is the correct answer. Crush artifact, thermal artifact, and gel foam artifact, as I already mentioned earlier, that these are pre-fixation artifact. Autolysis is an artifact which is because of the fixation or improper fixation. So what is a fixation? Fixation is a process by which tissue is preserved in a lifelike condition by preventing autolysis and putrefaction. So you do not want autolysis to setting, you do not want putrefaction to setting in the tissue. Tissue should be as it was. So that's why you fix it. For optimal fixation, the ideal volume of fixation fixative should be 20 times that of the specimen volume. I mean, this is really an ideal situation where it can happen. But mostly in the small biopsies, you will be able to put 20 times the fixative than the specimen volume. And most ideal fixative is a neutral buffered formula. So what can cause the fixation artifacts? Fixation artifacts can be due to improper fixation, can be due to delayed fixation. That means the specimen is delivered or the biopsy delivered, but it is not immediately fixed. It can be due to use of inadequate volume of fixative. As I already said, that the volume of the fixative should be 20 times the volume of the specimen. The use of unappropriate fixative. That means if you have got bone marrow biopsy and you are fixing it in a formalin, then it is not appropriate fixative. Inadequate time of fixation. I mean, you usually expect anything which is fixed should be from 6 to 48 hours. Like for a breast specimen, the ideal time which have been proposed that you should have tissue fixed between 6 to 48 hours. And prolonged time of fixation. Even if the fixation goes beyond the 72 hours, there are many things which can produce like artifacts are produced in the tissues, and it is not an ideal situation. So prolonged fixation is also not good. So let us take a poll question again. The question is, delay in fixation can cause following artifacts, except increase in mitotic count, autolysis, loss of antigens for evaluation of IC, and the fourth is all of the above. So let us wait for a few seconds so that our attendees can answer this question. Okay, what I can see that the most of our attendees have answered that all of the above, but there are also some of them have taken option of first option, which is an increase in mitotic count. So delay in fixation cause, you know that it can cause autolysis, you can cause loss of antigen during evaluation IC, but it does not cause increase in mitotic count. Actually, people have done studies wherein they found that the moment you start delaying the fixation of the any tissues, it actually decreases the mitotic count. It does not increase the mitotic count. What happens that for the mitosis, let's say the tissue, the cells are in a mitosis. Now, if you are delaying that the fixation, then that mitosis gets completed and the cells get divided, and you won't be able to see the mitosis. That's why you will get a decrease in mitotic count. So what is an autolysis? So autolysis gets cells in tissue once it is deprived of a blood supply. So during autolysis, there is a breakdown of cell components by hydrolytic enzymes, which are released from the lysozymes because lysozyme membranes get ruptured, and that's why the autolysis gets sets in. So how do you recognize that there is an autolysis in the tissue? Usually, when there is an autolyzed tissue, you see that there are changes like
Praveen, I think we have lost you.
Yeah, Praveen can't hear you. I just call him. Not connecting to him. Just yep. Ruchi. Just hold on for a minute. I think I'm trying to reach Praveen.
Yeah, I'm trying to reach him too, but
Maybe.
I get the message that his phone is switched off.
Yeah, means. Okay, Ruchi, I'll just call Ruchi then. Maybe you can request Lakshmi Narayan to start. Yeah, stop sharing the screen.
He has to stop, I think.
I think we're still seeing his application. I'll request Ruchi to stop. Ruchi can do that as a host.
Okay, good.
Yeah, please stop sharing. Perfect. Dr. Lakshmi Narayan, can you share your screen?
Okay, I'm sharing.
Okay. Yeah, Dr. Lakshmi Narayan, I think you can take over from here. You take your time, take it easy, and when Praveen joins, he will join you once you're finished.
Okay, anyway, Dr. Mahajan has covered many of the things in detail. I have not planned to cover it, but I will explain in a different way the points what he has touched upon. And there are so many articles available on this artifact, but practically when we speak, whether we are following all the points or not is the question, which I will just cover in few slides. The shrinkage, what we were telling about the fixation.
Yeah, Praveen, I think we lost your connection.
Anita, you're not muted.
Sorry, 1 minute, I'll mute myself.
Yeah, go ahead, Dr. Lakshmi Narayan.
Yeah, so approximately 10% shrinkage occurs while fixing a tissue, but this is not true for all the tissues. Different tissues behave in different ways. But this shrinkage is accepted in histopathology. Generally, that is accepted, and what we say as a gold standard of HMP slide, that 10 to 20% shrinkage. Sometimes it is 20%, but average 10% shrinkage is calculated. But introducing artifacts and more shrinkage should be avoided as this will affect the diagnosis, which Dr. Praveen has stressed in his slides. And why we are telling this is, it is a very common practice nowadays in the market to give the report very early. The time should be very. Today the specimen comes, tomorrow the report should be ready. So what are methods they can rush upon the specimen is the question. So introducing heat, introducing vacuum in every step. These are the things which are being followed. Here, what I want to mention is the company who supplies these automated processors also suggests that you can give every stage heat, every stage vacuum, every stage agitation, everything. All the processing is done in 2 hours time. In some of the machines, somebody said that it is 72 minutes you can process big tissues. The point is, for testing purpose, they would have done it. They would have done, but we don't know who has done it for 10 years. Nobody has done it because the machine has come to the market very late. So we have to try and then study whether the immunos also works on that, whether that gives how much shrinkage is there for the tumor nuclei. All these things we have to study. Just the company people says that heat is there, you can give and you can finish the process in 2 hours time. We cannot blindly follow it. That is what I want to stress there. Then heat is also applied in the fixation, which I have seen many places that people heat because the tissue has come in the evening and they just wanted the report to be given in the next day. So what is the shortest way? You heat the formalin and put the tissue in that, so the fixation will be faster. Again, remember the shrinkage will be more and it gives very hard for cutting and it won't give a good morphology. The 37 is acceptable for any tissue, anywhere heating. 37 is acceptable, not more than that. In the case of decalcification also, 5 days, 6 days, decalcification means nobody will tolerate, patient will harass, and doctors will say why the report is delayed. So people give 50 degrees, 60 degrees while doing the decalcification. So nothing will be seen as morphology, nothing will be there. I will show you a picture a little later. Then the artifacts can be introduced in any of the multiple steps before a slide is given to the pathologist. At the time of removal of biopsy, and that Dr. Mahajan has covered very well, time of fixation, that is whether it is fixed immediately or delayed. Here I want to give a little explanation on this delayed one. When you just look at the specimens from where we receive, in a hospital, definitely from theatre we expect, or sometimes many of the laboratories second opinion, or they send the tissue for some other places. The nursing homes or where the surgery is done, the surgeon wanted to show the specimen to the relatives. So the surgeon removes the tissue, then he completes his surgery, and then he shows the specimen to the patients, and then everyone takes a WhatsApp photo or photo and other things they want to send it, and then it is taken for fixation. So how much delay really has happened there? Nobody has bothered to see how much delay has happened. If it is a biopsy or something, it can affect, but if it is a very large tissue, it may not. But in case of breast and other cases that so many lectures have been given, so the tissue should be immediately fixed. Then transportation. The transportation, see again, a hospital, you can get it from the theatre. But when it is given for some other centers, when it is a long distance, suppose from Assam, somebody wants to send a biopsy to Mumbai or to Kerala, then how much quantity of fixative they have kept in the tissue? How many days it was there in the fixative? Because the courier itself takes sometimes 4 to 5 days. And then size of container, sometimes the large tissue is kept in a small container. And then here is the one when the overfixation happens or underfixation happens, then the zonal effect also comes into picture. Because if it is 5 days, a small biopsy with good quality quantity of fixative is kept, then overfixed, that tissue is overfixed. What you can do is really in that case, you have to assess really the pathologist has to remove the tissue, take the section, and then the technical person should wash it under tap water for certain level. How many people do this? I don't know, but that is the correct way of overcoming the overfixation artifact. Then underfixation, naturally, everyone knows that underfixation means varied results for staining, for immuno, for many other purposes. That is actually a zonal effect because upper side of the outer layer is fixed and the inner one is not fixed. Then during grossing, you have to clean the knife, clean the table without fail. Each specimen you have to wash the table, and these things are to be done meticulously. Then processing, the heating formalin, which I again stress, formalin, please don't give heat more than 37 degrees at any cost. And I have seen many laboratories doing that, boil the formalin and then put the tissue. You won't believe this statement, but I have seen it myself. Then grading of alcohol in the processor. And at this time, I want to tell that sometimes this artifact will overcome with some of the troubleshooting also. Both will come hand in hand. Grading of alcohol means again it will affect the processing. It will show some varied result after staining. And then absolute alcohol, if you are using, that is real ethanol. Then only the grading of 70%, 80%, 95%, and then absolute. Just blindly giving 70%, 80%, 90%, 95%, and one change of absolute. The real dehydration takes place in the last step, that is for nearly 1 hour, where the dehydration is incomplete. Then coming to the embedding heating forceps, which Dr. Mahajan has already mentioned, the forceps is heated, that should not be heated more than 65. So the control will not be there. If people are having the embedding machine, then that can be controlled. If it is not there, then heating or charring artifact will be seen. And sometimes, in the colder season now, yes, we were talking, in Delhi it is nearly 3 degrees, 4 degrees. So when as soon as you take out the cassette from the machine, it will be very much solidified. So heating the cassettes is a quite practical way of doing it, but the person who is doing it should be very sincere that the heating should not cross more than 60. Then after embedding, if the machine is there, embedding machine, then cleaning the well is important, otherwise carryover chances are. Then while talking about the trimming, avoid rough trimming. When I mentioned this avoid rough trimming, it is how many people have seen the seniors also cutting microtomy, I don't know. People cut, they also shake, their table also shakes that much faster they do. That is very wrong. The cutting and trimming should be done in a slow and rhythmic manner. Then only the sections will come. When you trim very rough way, then after the trimming you just cut, there will be many holes in this. And during flotation, directly in the water bath, 90% of the people put the section in water bath directly. So the folds cannot be removed immediately because the water bath is a hot one. And different sections also, they take 3 or 4 in one go, and then the one person will take the section from that. And there are chances that a lot of mistakes can happen. That means actually every section after cutting, you have to skim it and clean the water, and then only you can do it. Then section heating, that also Dr. Praveen has mentioned. Hot plate if you are heating, or in the oven you are heating after sections are taken on a slide, it should never cross 60, 65. But I have seen personally that many people heat it beyond 70 or sometimes 100. It reaches 100. Nobody checks the oven also, because an NABL accredited or some big hospitals only these things will be followed. The oven, like thing, they will heat it for 5 or they will heat for 20 minutes and then take for stain. Then staining there also, filtering hematoxylin is very important, otherwise hematoxylin precipitates can come. pH of alcoholic ammonia, if people are using alcoholic ammonia, that is important, otherwise that pH will change the whole staining. Then eosin also, if you are using alcoholic eosin, then the pH is very critical. And many other factors are there, as I said. If you heat the sections more, then also it will affect the staining. If the alpha max temperature is high, then also the staining will be affected. Many factors are there. Then cover slipping, generally the air bubbles are introduced. That is why people go for automated cover slipping machine or the tapes. But the air bubbles, when you introduce, when you scan it, nowadays the digital world, the slides are being digitalized, so the air bubbles will give a lot of negative. And heating after DTX, they mount to the section, then they immediately keep it in the oven for 5 minutes and then take out. There will be a lot of air bubbles introduced by that time. This should be avoided. Then storing, ambient temperature is preferred. At least don't store the blocks and slides in terrace. In some photos, I'll show you this over fixation or under fixation, loss of nuclear chromatin. That is an artifact. No, you cannot see. A gold standard HMD slide should be seen, which you cannot see. And this you cannot take it for digital pathology. Then shells engage and artifactual spaces. Varying staining results. These are the trouble when you do over fixation. Then what we have to do is fix specimens as soon as possible. Open uterus for endometrial fixation. Open GIT specimens for mucosal fixation. Open solid organs without fail and bisect lymph nodes. These things must be done by junior or senior or whatever person who is using should sincerely do it. Then many of the problems can be solved. Then autolysis. Autolytic changes, what happens is delay in fixation. We say then autolysis takes place. The other method is people transport the tissue in saline. People don't know what is in the solution, so any some water also they think any solution will do. So many times the specimen comes in saline. So what will be the result? The nuclear details will be poorly defined and it will be a dull cytoplasmic staining. So at that time, what we can do for solving this is fix the tissue again in formalin, and if possible, try to give a secondary. Depending on the tissue, depending on the size, you can give secondary fixation. Whatever fixation you want to give, you can give. I cannot mention what secondary fixation you have to use because different people use. Some people use wine fluid, some people use carbon fluid, some people use picric acid plus alcohol, and many types of fixators are there. But that will give a little better section and better morphological detail. And this is what I was telling, a small container, a big tissue, which was transported, it was lying 5 days in that, and then you receive the sample. Definitely there will be underfixation, there will be zonal effect, and then crush artifact can also happen. This crush artifact, he has already, Dr. Praveen has shown a picture. See, this is the one, damage crushing, one marginal section, darkly staining and distorted cells. And definitely this intense asphyxia is one of the striking characteristics. Then over decalcification, which many times happens because people don't check it and frequently they don't check. And then when it is over decalcified, this is the way that you cannot report actually. So destruction of tissue morphology. What we can do is wash thoroughly. This thoroughly I have mentioned because people just keep it for half an hour also, they think it is over. Initial stages, so many years ago we used to wash it for overnight also. Because nitric acid if you use, overnight washing is suggested. But nowadays formic acid is preferred, and then at least 5 to 6 hours washing is necessary. And if possible, give a 70% alcohol stage. That gives a very good morphology afterwards. People don't do it, but giving a 70% alcohol for at least 1 hour will give a better result. Then this is under decalcification, you cannot cut that section, very hard to cut. Then dark areas will be same. This is because they have not checked the status of decalcification frequently. Just they will put 2 days or 3 days, calculate, and they don't change the acid, and this happens. So then incomplete dehydration, this is a very common feature for the GI specimens. The cloudy appearance of section, loss of nuclear details. This is because of the insufficient dehydration step in the machine, where machines are there. And if it is not there, somewhere somebody has rushed the step. And this is what I explained previously, only one step of 70% alcohol is sufficient, and there is no need of putting 80 and 95 and other things. Then embedding, that is the local damage, that heated forceps. See here, surface or reverse section showing local damage caused by the application of heat during embedding. And then this is the trimming one, which I was telling, the rush and a rough trimming, these type of holes will create holes. So what we can do is blocks are always carefully trimmed exposed tissue. The last few sections are always cut at 10 micron or less. How many technical persons will do this? I wonder. But it is a must if you want to maintain a high standard and give a good standard HND to the test. And vertical scratches, which you have seen many times, this is caused by bad blade, calcium deposits may be there, the hard material is there, just like a thread or sometimes a stapler things. Then what you can do is use a fresh blade, or use a surface decalcification if you feel that it's a gritty area, is a calcium, and then remove the hard artifact if it is thread or stapler thing. Then this is the Venetian blind one. Over dehydration, that also can cause, dull blade can also cause, and too much blade tilt. This I have mentioned because I have seen quite few, not very many, quite few technical persons changing angle for each block. They don't keep the knife straight. That means they go on tilting the knife in order to get a good section. So that should be stopped. A good angle. In case of Leica, if they have kept at 5, you keep it at 5, and then you just do the job. But people are there few who changes the knife angle for each block. That should be avoided. Then cutting too rapidly also will create, which I told you while trimming also, for cutting also. Yeah, slow and rhythmic cutting is recommended. And flotation of sections, which I told you, a regular skimming should be done. Check water temperature, that should be less than 5 degrees, less than the melting temperature of wax. Then avoid overspilling. Sometimes people keep the section in water for more time. That should be avoided. Prevent bubbles under section, which will affect the IHC and ISH staining. See, this is the 2 sections have been taken in water bath, and then they may take one. I oversight, they can take this as other one, the number will change. This should be avoided, should never be done. This also creates an artifact only. If some other sections, just like this, here this is an artifact. See, this has come over, crossover, and then this is a carry over in the section. Then overspreading, again, this happens in lymphoid tissues are particularly prone to such cracking. That means the water bath temperature to be controlled. Don't leave the sections too much in the water bath and tissue not properly processed. Then also this can happen. Then this is the one which is the process in acetone. See, nice sections you'll get, but see the picture of the sections. So many cracks in the tissue. You know, the acetone processing, if you are using, the time is very critical. And dehydration time should be minimum. There is no need of what we will say, more number of changes in case of acetone. When bubbles under section, in case of INC, these bubbles will create some extra or unwanted brown colors. And here what happens is the darkly staged area with pale centers surrounding radial cracks are seen. This is because of the bubbles. Then monitoring drying temperature, which we already discussed. Dr. Praveen also said, I also told, after cutting the section should never be heated more than 65 degrees. When you heat it more, this type of melting down, nuclear meltdown is seen. So this is due to excessive temperature of the section before taken for staining. Then process the tissues also properly. If the wax temperature is also more, this can happen. And staining quality is affected by many factors, which we have already discussed. Waterlized tissue, you cannot get if it is heat is given more than 40 degrees, then also you cannot get. Then over decalcification, heat at high temperature, hematoxylin precipitates because it is not filtered, foggy appearance because of water content in xylene. That also is one of the causes. And the pH of use to be maintained because otherwise, the shade will change. Then cover slipping and storing, no air bubbles, no heating after cover slipping in the oven. Then quality of DPX also affects sometimes because the xylene content is more, means the more evaporation and air bubbles can get introduced. Then store the slides in a good ventilated place. At least don't store in terrace. No shortcuts in washing step while staining. In the staining step, if the washing is done for minimum, that also is one of the major causes of what we will say, the fading of nuclear stain and cytoplasmic stain as well. Check the pH of alcoholic ammonia daily. This daily is very important. Otherwise, that shows in the staining. And so, in conclusion, what I want to say is proper handling of specimens and avoidance of faulty techniques will reduce artifacts, thus help to establish correct. Thank you.
Thank you, Dr. Lakshmi Narayan, for saving the day for us. Now request, Praveen, you're there?
Yeah.
Yeah.
Sorry, my
You
internet
can
connection was
continue.
proper.
If you want, you can
Yeah.
continue from autolytic. Yeah.
Excellent presentation, Dr. Narayan. Thank you very much.
Lakshmi Narayan, you're getting lots of compliments in the chat box, and many people are showing clapping. I'm sure you can see that. Very good. Praveen, you're going to start. Can you hear us, Praveen?
Yeah, I'm trying to share, but there's some issue.
I think we have to make you. Hold
Yeah,
on.
she has not given me the presenter.
Yeah, I made you presenter. Sorry. Now you can share.
Okay, thank you. No, it's not happening.
Just one sec. No.
You given me the privilege?
Yes. I just asked Ruchi also. I mean, when you click on the share, it doesn't work.
No, it comes, but when I press final thing share, it's not happening.
Just one sec. What does it say when you click on the share?
Nothing it says actually. Initially it was saying that you need privileges for sharing. Now it is, even that is not coming.
One sec. Ruchi, Dr. Praveen is not able to share his screen. Open the bath, just come to the tell him. Ruchi is coming to tell you. It should guide you, know.
Sir, if you don't mind, can you please rejoin again?
Okay, so should I leave the meeting and rejoin?
Yes, yes.
So, Dr. Lakshmi Narayan, you have 2 more minutes if you want to share something.
No, not now. It's okay because I can speak more, but you have given me around 10 minutes, so I just made few slides and then that's it. That's why there will be an overlap of troubleshooting as well as artifacts. So the main point I wanted to stress is those things where most of the people, when they receive from outside samples and other things, in a hospital, major hospital or an accredited hospital, these many problems may not be there.
It's amazing, Lakshmi Narayan, where accredited hospitals also have similar.
I also have. I cannot. I have seen it, but what people should follow the instructions. They should listen and then they should follow. That's the only thing.
Praveen, sir, I made you a presenter. Just wait.
There, it's happened.
Yes, it's just make a full screen, sir. Yes, it's visible. Sir, please unmute yourself.
Can't hear you.
Praveen, we can see your screen.
Yes.
Have you unmuted?
Yes.
Yeah, so sorry for that problem. And Dr. Lakshmi, I was hearing to Dr. Lakshmi Narayan, and he has covered many things which I was going to cover in my subsequent talk. What I like about that, he has also covered the remedies of those issues. Also, he being a histotechnologist, he has very nicely covered those. I was talking about autolysis when my connection went off. So if you see in this images, the left-hand images is actually a bronchial biopsy which was received in saline. Now the many radiologists as well as clinicians have a habit of sending stuff, one in formalin, one in saline, and sometimes they don't even know that they don't have to send it in saline. So this was completely came in saline, and as you can see from the image, that you cannot make out head or tail of this of the tissue. Nothing. I mean, it is just completely autolyzed. You cannot make out any cellular details. There is so much bluishness in the tissue. Probably there is even overgrown bacteria there in the tissues, and you cannot say anything. On the right hand side, the two images are showing the uterus which is inadequately fixed, and you can see that the glandular details are not at all seen because of the autolysis. But you can make out something about the stroma. So what happens during the autolysis? Actually, the glandular epithelium is so sensitive, it starts to autolyze first, and the stroma usually can withstand some amount of autolysis. So you may be able to make out some stromal structures, but the glands they could just go away. And so the left hand side it is completely autolyzed. On the right hand side it is partially autolytic tissue. Dr. Lakshman also mentioned about zonal fixation. It usually occurs in tissue which has got the capsule. Now, this is a lymph node section. It is a case of a lymphoblastic lymphoma. You can make out that in this section on the right hand side, the cellular details are quite well preserved because the fixation has happened from the capsule inside. You know that the formalin text, when they penetrate into the tissue, it is 1 millimeter per hour. That's how the penetration rate is. So the tissue which is nicely blue and very nice compact is actually well fixed. But if you see on the left hand side, the tissue is not so well fixed. That's why you can make out that the cells are quite rather discohesive. And if you look at the high power within this tissue, that well fixed tissue, you can make out nice nuclear details. You can make out the blastoid morphology. You can see the histiocytes also, which is giving a starry sky appearance, which is everybody so likes. And on the left hand side, the tissue, you see the nuclei so now become small. The cytoplasm is hardly seen. You can make out that they're kind of looking discohesive. So this is what happens when there is a zonal fixation. The one area gets fixed properly, and the other area doesn't get fixed properly. And that can even pose problem if you are doing immunohistochemistry. Now coming to the next the artifact which is called as a formalin pigment artifact. So in a long-standing formalin, when the tissue is kept for a long time in a formalin, what happens that the formalin starts to produce what is called as a formic acid, and which lowers the pH and makes this formalin acidic. Now in this acidic environment, when this formic acid reacts with hemoglobin, it starts to form what is called as acid formaldehyde hematine, which is nothing but a formalin pigment, and which then precipitates in the tissue, which is a hemorrhagic tissue like tissue in the spleen or liver or lung, where there is a lot of sinusoidal vasculature. You see that there is a precipitate of black to brown finely granular formalin pigment, and once it is set in, you cannot remove it. So it is also not a good idea to keep the tissue for a long duration into the formalin. Now the ideal situation here is that you should use a neutral buffered formalin, because there the formation of formic acid takes a little longer. But eventually, even if you keep tissues longer time, even in neutral buffer formalin, the formic acid will start to happen, and you will get eventually formalin pigment in that tissue. Now this is a liver biopsy, which is you can see that the liver biopsy on the left hand side the image that it is fixed in formalin adequate time, and you can see the adequate cellular details and everything can be made out. But on the right hand side the image, you can see that the liver tissue has been fixed for a prolonged time. That's why there is a shrinkage of the cells. There is an artificial emptiness around these ducts, and you can start to see that there is some brown black pigment can be seen around the sinusoids, and that is a formalin pigment which has been set in. Now again on the left side you can see that there is a hemorrhagic tissue which after prolonged fixation there are this very brown black pigment which has precipitated within this hemorrhagic area, and this is called as a formalin pigment. Now that can be confused sometimes for melanin pigment or variety of other pigment. That's why it is very important to know that how the formalin pigment looks like. Coming to the next artifact during the fixation, that you can have a freezing artifact. It usually happens in a tissue which are frozen earlier, like the tissue is received in the frozen section. You might get that artifact. Sometimes what happens that the tissue is taken in the evening. They cannot transport it immediately to the lab, so they put it in a freeze. Now once they put it in a freeze and mostly in the freezer, then the ice crystal starts to form within the tissue. Now when the ice crystal form, and then next day when they are taken out of the freeze and put it in the formalin, the ice crystal get thawed, and you will start to see when you process that tissue and see under the microscope, you will start to see that there are interstitial vacuoles and sometimes even the cytoplasm. So these are the two examples here. On the left hand side is a brain tumor, and then on the right hand side image is a breast mass biopsy. In the both biopsy, this tissue is completely frozen, and you can make out that these are the rectangular shaped crystals which had formed within the tissues, and the rendering tissue completely useless for any diagnosis. You cannot make anything just because of the history there that it is a brain tumor. Just because it is told that it is a breast biopsy, I have written that this is what it is. Otherwise, you cannot make out any tissue in this, and it is completely gone. So this is a severe or major excessive artifact which has rendered it difficult. So this is a dye artifact. We use, everybody knows that we use ink to show what are the surgical margins of excision, and there are different things can be used. There are proprietary inks which can be used, like camelin ink is there. It should not be, the property of this dye should be that it does not get washed away during the processing. That's why you'll be able to see it after the processing and when the staining is done. And it is used to show whether we see what are the margins are there, whether the adequacy of the margins is there or not. Now this is a tissue which is a thyroid tissue, in which you can see this spaces which are like needle-like spaces. This is what are called as cholesterol caves. These are usually formed around areas of hemorrhage, or there is a lot of inflammation is there. What happens that the cells break down and they start to form the cholesterol caves. These cholesterol caves get washed out during processing, and you see these empty needle-like spaces which are called cholesterol caves. The best example, if you have to see that there is a loss of soluble substance here. In this case, it's a cholesterol which has got lost during the processing. But the most the very what shall I say good example if I have to give is like a normal adipose tissue. If you see that the lipid cells, they look the adipocytes look quite vacuolated, complete vacuole, because the lipid within the cells have got washed off during the processing. Now, Dr. Lakshman Narayan has already talked about decalcification artifact. On the left hand side, it is under decalcified tissue. You can see it still looks quite blue because calcium has not been properly taken out or placed on the tissue, and that's why it's looking blue. And it can interfere with your interpretation. Also, what happens if the tissue is under decalcified? You will not be able to cut it properly. The sections will not be proper. So that's why you can even see the folds, or there is a displacement of this bone within the tissue. And when you over decalcify tissue, there are also the problems. If you're over decalcifying, the stains are taken up properly. You see here that the tissue looks all pink only because hematology is hardly ever there. So this is also a problem because of over decalcification, and that's why under or over decalcification should be avoided. Now, if you have to take a poll question, like what is the cross contamination or tissue corridor or floater, which Lakshmi Narayan already pointed out, in which stages they can occur: crossing, embedding, sectioning and slide preparation, and staining, or all of above. So judging by the responses which are given by few of our attendees, most of them got it right that during all these stages you can get the tissue carryover or the tissue contamination. Now this is a bronchial biopsy. On his left side, you can see this in this section that there is actually underfixed bronchial biopsy. These are these bits which are underfixed tissue. But what is seen here is another tissue here. It's completely has got a different hue. This area on the left side is actually bronchial mucosal tissue, but this is something which is different. And if you look at it, which has been circled here, and if you look at on the high power, this looks like a completely different tumor. And the bronchial biopsy, which is underfixed, as it looks quite different. So this is what was a cross contamination or a tissue carrier or the floater in the tissue. So this is what when do you call it a carrier or floater? It is when the tissue which appears on a slide do not belong to that particular site. It can be included during crossing, it can be included during processing, or it can be included during the flotation of the cut section in the water bath. If you don't do the proper skinning, as Lakshmi Narayan has already mentioned, it can happen during crossing that it is a dirty crossing table, your dirty clothes, your forceps are dirty, and you are using it for the next case without wiping everything. Then you can have this cross contamination. When you are transferring from one cassette to another, also during processing, there can be carryover. It can also during the embedding also it can happen during the flotation of the tissue also it can happen, and sometimes during staining, sometimes the tissue can get lifted off and can go into another slide. But usually it occurs during the cytology thing, because the cells can get dislodged from one smear or one case and can get deposited on another smear while it's staining. Now, there is actually a subtle difference, or there is a difference between a carryover and a floater. Carryover means it is actually a tissue, something which is carried. Now, carried from where? It can be carried during the grossing by gloves or by forceps, or it can be carried over from during the embedding also, because the forceps which you are using for embedding the small tissues, you are not cleaning it properly. That's why it can get carried over from one case to another case, and also during the flotation bath. Floater is only in the flotation bath because you're floating the tissue there. That's why you get the floater there. Now, how to differentiate something is a carryover or floater? It's very easy. When you have carryover, when you take a ribbon of the tissue on the slide and you get a recut. Let's say this is a recut of one of the biopsies, and even in the recut, you're able to see that contaminated tissue, and if it is also present in both the ribbons or the whatever multiple ribbons you're taken, that means it is a carryover. And if it is a floater, it will be only seen in one of the sections, or it will not be seen in a recut. That means it is a floater. These are the what are called as knife lines or knife scores, which are due to the damaged cutting edge of the knife. So if you're using disposable knife, your technician has to be careful that they don't use the knife which has been damaged. If it is not, you're not using reusable knife, then it should be sharpened periodically. So sometimes knife scores can be few, but they can be so multiple. And as Lakshmi Narayan mentioned, that if something is scanned or your images go somewhere, it can be an embarrassing situation. This is a post chatter which is there due to because if you are using a very large tissue like uterine section or a cervical section and then trying to cut it, and you can get such a very big defect which are called post chatter. These are again he has already mentioned that it is because of a rough thing. This is the Venetian blind artifact which is already mentioned, and it is caused by loose knife or a different angle of the knife, and so I'm not going into details. So Venetian blind is actually this blind which we use in window. That's how it looks like. That's why it is called Venetian blind. This holes in the tissue has already been explained. These are usually caused by very rough sectioning. So avoid rough sectioning. It should be slow, and then you'll be able to avoid the holes. Even because of the spreading in the flotation bath, also you might get holes. Bubbles on the section, which is already mentioned, because this is like you see this circle in this tissue, wherein it has got different staining properties than the adjacent tissue. Because this the bubble which was there under the section when the section was taken on the slide, and then it was dried, the bubble the collapsed, and that's why there is a cracking artifact which has happened. And because the tissue is uneven at this side, the staining has become the uneven. Now there can be sometimes a residual wax on the section. You are not cleared it properly. That's why staining is a problem. You can see in the center of this slide, this image, that the staining is not so proper. Whereas in the periphery of the section, the staining is good, because in the center the wax has not been completely removed. So your clearing stiff has to be good. You can restain it after clearing it properly. So this should be avoided. Tissue folds can be minor, like in the left hand corner image, and can be major. In a small biopsy, it can be a problem. So this should be avoided. And bubbles under the cover slip can also be a problem if you are not careful while mounting. Then you can have one or multiple bubbles in the cover slip, and so you need to remount these slides again. Improper orientation is a big headache for pathologists. This is a squamous epithelium or squamous mucosal biopsy. You can see that actually it is a case of pseudoepithelial hyperplasia of the squamous mucosa. But if it's not properly oriented, there is a lot of headache to us, because you might then start to suspect whether you are dealing with something like articular squamous proliferation, which is like a squamous carcinoma or not. So the proper orientation, even for GI biopsies, is very important. Your technologist should be well trained about it. And if this keep on happening, then you have to go back to your technologist and tell them that they have to embed it properly. This is on the left hand side is actually is an IHC slide, and right hand side is an HNE slide. You can see that in IHC slide something has taken up this cytokeratin A1 A3, which is not the part of this actually of the tissue. And even in HNE you can make out there is something which is floating here within this whole thing, that these are actually squamous cells which have contaminated this section. These usually come from the fingers of the technicians or the skin of the technician, and that can cause a challenge or a problem sometimes. Sometimes when the stains precipitate, especially in a cytology, if stains are precipitate and it is not filtered properly, then you can see the stain deposited precipitate on the smear. If there are too many, then even it can hamper the evaluation of the cytology. When the slides are not kept properly, like not in a proper ambient temperature, if there is a lot of heat in where the storage happens of the slides, then you start to get what is called a fading of the staining or bleaching of the staining. And also sometimes there is this, you can see there is a very small droplet like thing. This is actually the crystallization of mountain which has happened, and because it is not stored properly. So this should be avoided. Now, just to make things lighter, this was the poll question which I had included. Which of the following image does not represent an artifact? Image A is a thyroid tumor. Image B is actually a lung tumor. Image C is actually a lung tumor again. And D is a soft tissue tumor which looks like a adipocytic tumor. So actually none of this is actually an artifact, and I will tell you how. If you see that I have already mentioned that the normal adipose tissue, when this adipocytes has actually look like that because the lipid within the cells has washed off because of the processing. Similarly,
in a thyroid tissue, the nuclei which has got this very open chromatin and they look quite vacuolated or quite empty because this is actually an artifact which is produced during the processing. And if you see this during the frozen section, you don't see such nuclei. That's why it becomes so difficult to make the diagnosis of papillary thyroid carcinoma unless you have got a proper papillary. So if it is like NIFTP or follicular variant of papillary carcinoma, you are going to struggle because you're not going to see these nuclear changes which usually happen after the processing. Even some people believe that intranuclear inclusions which you see in thyroid papillary carcinoma is actually an artifact. So we see this nuclei of the papillary thyroid carcinoma as orphan Annie. This is actually is a cartoon which is a comic which runs it used to run in a daily newspaper in USA. So this if you see this orphan Annie, the name is Annie. She was orphan Annie, and you can see her eyes, they look quite empty, and that's why this nuclei, somebody thought that they look like an orphan Annie nuclei. The second image was of a small cell carcinoma of the lung, and you can see that there is a crushing artifact and a nuclear molding here, which is a sign. This is an artifact, but which is helpful for us making diagnosis. This is an artifact which is a retractant artifact which happens in a basal cell carcinoma. Is quite a useful sign. If you see this retractant artifact, something which is a basoid tumor in the skin having peripheral palisading and retractant artifact, and most often this is going to be a basal cell carcinoma. In cytology, lymphoid bodies is an artifact which happens in tissue or smear aspirate which has been taken from a lymphoid organ. You can see that there are the cytoplasm gets detached from the cell and it forms very small bodies, round bodies. This is the HN stain on the left side and right side is the PAF stain. In both you'll be able to see the round bodies which are called lymphoglandular bodies. What gives you so this gives you an impression that what is something you are dealing with has got lymphoid soil or it is a lymphoid rich aspirate. I will end my talk with this wonderful case, which was contributed by my colleagues from Israel Farke. This is a 33-year-old male who had a swelling on the right side of his scalp, and this swelling was there since quite a few months, but he started bleeding. And so this fellow was applying something on that bleeding. Now, if they did some excision about it, you can see that there are these large blood-filled spaces or vascular channels in this within the scalp, which is nothing but you can make out that it is like a cavernous hemangioma. But what is interesting here on the top of this the skin, you can see something which look like these round or rectangular bluish particles. And if in high power you can make out then in the scalp, it definitely looks like something like could be a vascular lesion. And on top of it, there's something looks like you have never seen in histology or pathological sections. So there is something which is round or rectangular or irregular shaped. These blue structures can be seen on high power. You can make out again on high power. You start to see they're more rectangular and something is quite unusual for any human tissue. And elsewhere it looks so yellowish also, like apart from these bluish particles, the stroma in between or whatever the spaces in between, it's not a stroma or whatever. It looks so yellowish. Quite unusual structure. So what suspected was this is definitely an artifact, something this patient was applying. So they got an history. This patient was applying a turmeric on this bleeding hemangioma, and that's what it was giving this appearance. Now, because they wanted to prove that it actually was a turmeric, they got actual turmeric from the market and they processed in the lab. And you can see that this processed turmeric also shows the same structure. So that means it was indeed that patient was using turmeric to stop the bleeding. So that was an artifact, and it was quite an unusual case. That's why I thought I will share with you. To conclude, that artifacts in histopathology can introduce in various stages, right from when the sample is collected till the end result of staining. These artifacts can be minor and major. A major artifact like catalytic artifact or frozen artifact can be very severe, rendering tissue completely useless for diagnosis. So that's why it is important to recognize artifacts so that you can avoid it. You can take remedies to avoid them. So I will conclude my talk with this, and I'll be happy to take the questions. Thank you.
So there is one question that how to differentiate formalin pigment from hemosiderin and melanin pigment.
So hemosiderin pigment, you can do the push and blue staining, and that way you will be able to differentiate from it. Melanin pigment, now what tissue you are seeing, that gives you clue. I mean, if it is not a hemorrhagic tissue, which is like a spleen or liver or anything, and you can actually see the cells which are like melanocytes or malignant melanocytes, then you will be able to make out that it could be melanin pigment. And you can also do spacer stains for that also.
Can I just ask Lakshmi Narayan one thing in respect of the same thing? Is formalin pigment bleachable?
Is formalin pigment?
Can it be bleached? Say you use a
Yes.
potassium permanganate bleach, which will bleach melanin. Will it bleach formalin?
Yes, we can.
Actually, if you use, it can be, most of the pigments can be bleachable, madam. Because if you
Okay,
use
this
strong
is-
bleachable agent, you can bleach the any pigment actually.
Yeah, except for carbon. You can't bleach carbon.
Yeah, maybe.
Except carbon.
So that's right. So if you the important thing is that you can't use bleaching as a way of saying that this is melanin, because almost anything can be bleached except for carbon. Carbon in tissues cannot be bleached, and if you do have something that is fine carbon that is somewhere and you're not sure what that is, if it's not bleachable, it is carbon. That's the general rule. Am I right, Lakshmi Narayan?
Yes, yes, ma'am.
Yeah. Okay. Good. Are there any other questions?
No more questions, ma'am.
All right. I think that this issue of artifacts, I think Praveen made it very clear that artifacts can be introduced right from the time that something is removed to the time that it arrives on a pathologist's table. But what I don't know whether all of you realize that everything that we see, whether or not all of these things that Praveen and Dr. Lakshmi Narayan have talked about, is all about artifacts. There is nothing that comes to us that does not have an artifact. The only thing is, and I don't know, Ruchi, if you give me, or whoever can give me the rights to just share a brief presentation, I think it makes some sense. Can I share my?
Yes, ma'am. I made your
thank you.
presenter.
Okay, so let me just share this with you. See, people have to understand something, that this is true of everything that we as histopathologists, hematopathologists, cytopathologists do. All our tissue diagnosis is based on the interpretation of a constant artifact. So whatever has been talked about today is about keeping your artifact constant and not introducing in an irregular manner artifacts into tissues. And I'll just sort of tell you this in a minute. See, I think that this is the essential of any diagnosis. Okay, you need a good description. Then of course all the investigations, and you need context, etc. But our description, which we do in our heads every time that we're looking at tissue, is based on observations and the interpretation that we make of these observations. Now, if we want to make good interpretations, it means that our observations have to be have to be good. Now, what do we mean by good, right? Now I'll just show you this lymph node biopsy. And I'm sure now if I ask people, they will know after this lecture, by Praveen and then all the things by Lakshmi Narayan, this is a lymph node you can see, and you can tell very clearly that there is what people are calling an artifact. Okay, but I got this as a second opinion case, and I said it is possible that this is Hodgkin's lymphoma, but it requires another biopsy for a definitive diagnosis. Okay, but somebody had made a diagnosis of Hodgkin's lymphoma. Was he or she wrong? The question you have to ask after this another biopsy was done, yes, it turned out to be a Hodgkin's lymphoma. In this case, it's probably nodular lymphocyte predominance Hodgkin's. So the question you have to ask is, why is it that one pathologist on this made the right diagnosis on this material, and I could not make this diagnosis with any confidence on this material? Okay, you can see that there are some large cells over there, and obviously this is this part of the tissue which is, right in the center. And the reason is this: all tissue diagnosis is based on the interpretation of a constant artifact. If some pathologist is constantly getting what I would consider bad tissue, and Dr. Lakshmi Narayan and Praveen have gone through the whole story of how you can get good tissue sections, how is it then that there are pathologists who are able to make diagnoses on tissue sections that, I and many other people would consider not at all good? Okay, so those who are used to a particular artifact can make diagnoses that stump others, and this is something that I think everybody should realize, that diagnostic criteria also on the same tissues vary with the method used to obtain the tissue, and I'll show this to you now. Okay, you see on one side you have a smear, and that is stained with Giemsa, and this is from an effusion, ascitic fluid, and on the other one it is a cell block stained with H&E. Now the two things don't look alike. All right, the artifact has been introduced, right? Whether it is a drying artifact because this is stained with Giemsa, and on the other hand, this has been fixed, and therefore you have an artifact over there of formalin fixation, and it looks very different. So each one of us in our heads, when we are used to seeing tissues prepared in a way that there is an artifact, we set in our minds this constancy of the artifact, and therefore we are able to make diagnoses. This is true even of marrows. This is an ALL, and you can see what it looks like in a smear and what it looks like in the bone marrow. Now you may say, yeah, but these are good preparations. How do we know that they are good? Okay, the issue is, if you are going to look, and just now Praveen showed you this routine fixation and processing of a thyroid carcinoma, which is showing the orphan Annie nuclei, but this is the frozen section of the same case. Do you see the orphan Annie nuclei? No. But if you have fixed this in your head as this is how a frozen section on a thyroid carcinoma, a papillary carcinoma will look like, then you're not going to miss this diagnosis. And then I'll show you what happens to this after this frozen block is thawed and then processed routinely. It doesn't have the artifacts that you were expecting to see in routine fixation. So everything that we see, whether it's the orphan Annie nuclei, which is not there in the frozen section, and it is a different kind of artifact that you see in the processed frozen section block, we are introducing artifacts galore. Okay, so the question that we have to ask then is, what is good histological preparation? And I'm telling you that there are people who will make diagnoses on material that I would hesitate to make a diagnosis on. So I would ask the question to Praveen as well as to Lakshmi Narayan, why do we say that something is a good histological preparation? There are people who will make diagnoses on something that is less than what we would consider good. And the answer that I have thought about for a very long time, because we're all doing histopathology now for years and years, is that whatever the artifact is, you must keep it constant. That's it. It's good if it is interpretable by the majority. Subtle features should be evident. So if you've got an artifact which does not allow subtle features to be seen, then that's not particularly good. Serial sections of the same quality can be obtained. So if you've got bad fixation, bad processing and stuff, does not allow serial sections of the same quality, then that is a bad histological preparation. And finally, I think both Lakshmi Narayan as well as Praveen said that ancillary techniques should be optimally applied. That means that this preparation should allow you to apply ancillary techniques, whether it is it's immunohistochemistry, it's other special stains, or even now in this day and age, molecular methods. Okay, and I think you've seen this. This is a freezing artifact. You can't make any kind of diagnosis here. So this is obviously a very bad histological preparation, because when you observe it, all you can see is a lacy network of holes of varying sizes. Okay, amphiphilic, etc. That is the observation that you make. Now, what interpretation can you make of this observation? Okay, the interpretation could be sponge has been biopsied, or you would say never seen this before, so I can't interpret. But you know that this must be tissue because somebody said that a lymph node was biopsied and it was received for grossing. Okay, so it must be something in which a gross, very, very gross artifact has been introduced. And Praveen showed this to you, and now we are all very aware that this is a freezing artifact. In other words, somebody has frozen this tissue slowly and thawed it slowly, because we do routine frozen sections. No, and we never see this artifact. We don't see this because we freeze rapidly and we thaw, quickly, and therefore you don't get this ice crystal formation. You don't get these little. It looks like outlines of cells in which something had frozen and now has been leached out of the tissue. All right. So that's the artifact. So I just want you to understand this: that all our diagnostic criteria are based on a constant baseline artifact, and we should keep this baseline artifact near constant and reproducible as possible, so that when you send it out for another opinion or somebody else looks at it, these four criteria, these are my criteria. It should be interpretable by the majority, subtle features should be evident, must allow serial sections, and ancillary techniques to be. This is just something that. So I'll stop sharing my my PowerPoint, because I think that we talk loosely about artifacts, yes, but everything that we do is essentially creating an artifact in the tissue, except that we should keep that artifact as constant as possible, so that there is no variation from one person to the next, to the third, to the fourth, and it should also not be such that in your own lab, one day you're seeing tissues that you can recognize well, and then something else pops in on the next day. So that's when we talk about artifacts, we must know that there is no tissue that you ever see that does not have an artifact. That's all that I wanted to add to what Praveen and Dr. Lakshmi Narayan said. So if there's any questions now more for Dr. Lakshmi Narayan or for Dr. Praveen, I think I'm sure that they will be happy to answer.
No more questions, ma'am.
No more questions. Oh, okay. Good. But I think Praveen and Lakshmi Narayan, you did a really good job.
No, I always like this